Now going into their natural history. And again, this is how we decide whether or not to treat these aneurysms. When you're deciding if anything in cerebrovascular disease, am I going to treat it or not, the first question asked is, what is the natural history? And then I'm going to talk about two very important natural history studies. So the first is ISUIA, the International Study of Unruptured Intracranial Aneurysms. This study was almost 20 years old now. This was a prospective evaluation of a cohort of aneurysms, but it's important to emphasize that this was a selected cohort of aneurysms where they decided some of them were treated and excluded from the analysis and others were included. So you already have some selection bias where perhaps high-risk aneurysms were treated. Now, initially, there's sort of a notoriously studied prior ISUIA study, the retrospective study that was published in the New England Journal in 1998, that quoted an extremely low rupture risk for cerebral aneurysms that is really no longer accepted today. Just to briefly state, they cited a 0.05% per year risk of aneurysms, risk of rupture for aneurysms less than 10 millimeters, which is just inaccurate. I put this slide up almost for historical purposes. So this is the prospective component that was published in Lancet. They looked at aneurysms over a 7-year period, although the majority were for the last 2 years of the collection period from over 53 centers. And again, this study did have patients that were treated. You can see more patients were treated than were observed, but 1,692 patients did not have aneurysmal repair, and they were followed over a mean follow-up of 4.1 years, stratified in group 1, whether there was subarachnoid hemorrhage from another aneurysm, group 2, if they had subarachnoid hemorrhage from another aneurysm, and the patients were removed for follow-up if they were treated or if they passed away. And so this is really sort of the money slide from ISUIA. Basically 51 patients, 3% ruptured. You can see the mortality from rupture was 65%. And so this chart is the 5-year rupture rate. So a lot of people annualize rupture rates. So you have to actually divide these numbers by 5. So patients without a subarachnoid hemorrhage, actually, if they had an anterior circulation MCA or ICA aneurysm, were quoted as having a, quote, 0% risk of rupture of less than 7 millimeters. This is a highly biased cohort, though, where patients with perhaps irregularities or higher risk small aneurysms were probably treated. So the actual risk is not 0%, but in this study, they quote 0%. If you had a posterior circulation or posterior communicating artery aneurysm that was less than 7 millimeters, your risk of rupture was 0.5% per year or 2.5% over 5 years. And everyone can sort of review or take a snapshot of this chart. You can see they went up to 7 to 12 millimeters and then 13 to 24 millimeters. And if you had a giant aneurysm in the posterior circulation or the PCOM, the risk of rupture was 50% over 5 years, or annualized, that's 10%. And they found that basilar apex location, PCOM location were higher risk factors for rupture, and obviously cavernous aneurysms, unless they're extremely large, are extradural and thus don't have a risk of rupture. Perhaps a more applicable study, although it was exclusively done in Japan, is the Natural Course of Unruptured Cerebral Aneurysms in a Japanese cohort study, or a UCAS study, published in the New England Journal about a decade ago. This was a study of over 5,000 patients. You can see the selection here of the patients, and they included saccular aneurysms that were at least 3 millimeters. And they looked at a variety of risk factors associated with rupture at follow-up. They found that an irregularity or daughter sac was a significant risk factor that always intuitively guides our treatment. They found that size was a risk factor. They found that ACOM location was a significant risk factor for rupture, as was PCOM location as well. On the verge of lower risk were ICA non-PCOM aneurysms. We'll talk about that in a little bit more detail. They found, however, that another aneurysm with subarachnoid hemorrhage, smoking, family history, and multiple aneurysms were not significant risk factors, although these have borne out in other studies to be significant risk factors for hemorrhage. So the overall annual rupture rate was about 1% in this study. And that's just a crude, rough estimate that people generally quote for aneurysms. If they say, what's the risk of aneurysm rupture per year, it's about 1% per year, although admittedly it's a lot lower for small ICA aneurysms. And so the morbidity and mortality in this study from rupture was 29% and 35% respectively. And this is a really useful table that I've excerpted below. You can see that ACOM aneurysms that were only 3 or 4 millimeters had almost a 1% risk of rupture per year. And that was really the highest risk of rupture per year. But what's really also interesting is if you look at both the 3 to 4 and 5 to 6 millimeter cohort, the ACOM location, the PCOM location, and this undesignated other cohort were probably the highest risk locations. And what's interesting is this other cohort was largely comprised, and those distal ACA aneurysms that I allude to are actually sneaky high risk. They generally don't get very large. They don't grow to 7 to 9 or 10 millimeters because they generally rupture before they get to that point. So there is some clandestine evidence from this study, or suggestion from this study, I should say, that pericallosal aneurysms, in addition to ACOM and PCOM aneurysms, are higher risk aneurysm locations. And you can see the risk of rupture bearing out. I'm not going to say every single percent. You can look at how malignant large PCOM and ACOM aneurysms are, in addition to the steep rise in risk of rupture for basilar tip or basilar SCA aneurysms as well. And this was just a far less significant study of my own that I did when I was a resident, that stratified aneurysms locations by presentation and just even parsed out location and risk of rupture even more. And so the lowest risk we found was superior-hypophyseal aneurysms, and you can see superior-hypophyseal is at the top and was really the lowest risk location. Lower risk locations included ICA bifurcation, ophthalmic aneurysms, and then sort of getting up there were the PCOM, the ACOM, and again here the pericallosal aneurysms as well. So this is just, again, a detailed review of aneurysm location and risk of rupture as it relates to that. So to answer our question, to treat or not to treat, what is the natural history, right? So ruptured aneurysms have an extremely high risk of re-rupture. So we treat them across the board. Symptomatic aneurysms, those that are large enough or regular enough to cause third nerve palsies or vision loss, are treated across the board. They're thought to have a very bad natural history. But other factors, so the patient is very elderly, the relevance of a 1% or less risk of rupture per year becomes a lot less significant rather than someone who is perhaps very young with perhaps a more innocuous looking aneurysm. So I do factor in age when I decide whether to treat an unruptured aneurysm or not. Size is also a factor. I generally treat most aneurysms more than 7 millimeters. If they're less than 5 millimeters, I look for other factors that would push me to treat, such as an irregularity or something, but otherwise I usually use that as a cutoff towards conservative management. As I've mentioned in detail, location is very relevant. So superior hypophyseal aneurysms and ophthalmic artery aneurysms, unfortunately, they are definitely overtreated, I think, in this day and age, because people like to put flow diverters across them, but they generally tend to be fairly low risk aneurysms for a lot of patients. So unless they're irregular and so forth, they can often be observed. On the other hand, even small ACOM and pericallosal aneurysms tend to be high risk, and we should probably have a lower threshold to treat these aneurysms. And certainly if the aneurysm harbors an irregularity, that should be treated. So this is an example of an ICA terminus aneurysm in a patient that had been lost to follow-up that had been treated for contralateral aneurysm.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.